So here's the first lecture of the infectious disease competency. Hopefully it's going to be 3 lectures that are going to be under 40 minutes, and then there will be a test afterwards. If you have any questions, please feel free to see me. So some of the objectives are to define what antimicrobial stewardship is. It can mean different things to different people, and just want to make sure we're all on the same page. Be able to interpret culture data. Identify the differences between colonization and infection, identify antibiotic options for specific infections, identify resources to assist with antibiotic selection for specific infections, and apply guidelines to determine appropriate antimicrobial therapy. Part 1 will not address all these objectives, but we'll address a few of them. So what is antimicrobial stewardship? So it's a system that promotes the optimal selection, dosing, and duration of antimicrobial therapy throughout the course of use. Its purpose is to limit inappropriate and excessive antibiotic use and to improve and optimize therapy and clinical outcomes for patients. So basically, are we picking the right antibiotics? Are we using them for the correct duration of time? Are we de-escalating them as appropriate? And are we looking at resistance patterns and evidence-based guidelines to drive care? So what does antimicrobial stewardship include? Well, it includes informatics. Obviously, our computer systems play a big part. Century 7 has some triggers, and we're going to be building more. Data collection, so looking to see how well we're using different things. So, for instance, there's different medication utilization evaluations that the folks who do drug use policy conduct. So, for instance, we might take a look and see what we're using ticacycline for, figure out if it's in alignment with the guidelines, and figure out if it's the best agent for the infections that it's being treated or that it's being used for. It involves a lot of different healthcare workers. So typically on a team there's pharmacists, physicians, infection control specialists, microbiologists, so people who look at things from all different angles to try to come up with the best policies, procedures, and protocols for the things that we do here. And then there's policies and procedures, so you really have to have support documentation in order to back up appropriate use, to have things that people can refer to. It might even be educational references or clinical algorithms. So it's basically whatever we can do to help drive appropriate antibiotic use. And it's practiced at the level of the patient, the healthcare facility, and the system. So we take a look at our resistance patterns throughout the community, those patients that we serve. We look at it in the healthcare facility, so we look in the hospital to see how are we using different items, are we overusing, how are we comparing to national standards. And then at the level of the patient, so what are the needs of our individual patients, and are we addressing them appropriately? So before we dive in, we need to go over some antimicrobial basics, so just some basic definitions for things. So one of them is the break point, and the break point is the minimum inhibitory concentration that is used to designate between susceptible and resistant organisms. It is a specific value that is determined based on the antibiotic and the pathogen pair. So each antibiotic and pathogen will have its own uniquely determined break point. The minimum inhibitory concentration is the lowest concentration of antimicrobial that inhibits bacterial growth. Then there's also the minimum bactericidal concentration. So that's the antimicrobial concentration that kills bacteria. Bactericidal means antibiotics that have a similar MIC and MBC. And then there's bacteriostatic, which are antibiotics with a lower MIC than MBC, and they only inhibit the growth of organisms. So we'll talk about a little in a few slides which antibiotics out there are bacteriostatic versus bactericidal. Then there's something called a post-antibiotic effect. So it's the persistence of antimicrobial activity after the removal of a drug or after levels have dropped below the MIC. There are some antibiotics that just seem to continue to persist to have an effect even though they don't have concentrations above the MIC. One class of antibiotics that seems to have a significant post-antibiotic effect are the aminoglycosides. Then there's time-dependent killing. So that's when the bacterial eradication is dependent on the amount of time that the blood levels of antibiotic exceed the pathogen's minimum inhibitory concentration. So we call those time-dependent antibiotics. It's also known as time above the MIC. So the time must be above the MIC 40 to 50% of the time in order to ensure that the antibiotic has efficacy. Sometimes you can use continuous infusions. We've used extended infusion protocols here, specifically with cefepime and with Zosyn. When patients go to home care, sometimes the continuous infusions are the easiest way because they can just fill up a CAD pump full of antibiotic solution and run it over 24 hours. And this works well because the antibiotic is a time-dependent killer and not a concentration-dependent killer. So then what's a concentration-dependent killer? That's when bacterial eradication is related to the maximum concentration that's achieved in the bloodstream versus the minimum inhibitory concentration and the AUC versus MIC ratio, so how much exposure the body has to the drug. So concentration-dependent killer antibiotics, we think of a class like that as quinolones, aminoglycosides, and then there are some that are more AUC versus MIC ratios, and that would be vancomycin and some others. We'll go over those in a little bit. Then there's synergy. So that's when you use two antibiotics together so that you could bolster the antibiotic activity of one of them. A really good example of synergy is when you use beta-lactam antibiotics with a low dose of aminoglycoside. So most frequently you see it being used with gentamicin. The gentamicin helps to kind of slow down the bacterial activity and make it more susceptible to the beta-lactam. Then the beta-lactam can invade the bacterial cell, causing it to break apart and disrupt its peptidoglycan structure. So that's just one of the ways that synergy can work. Synergy does not mean to use a therapeutic dose of the boosting agent. It is basically using a lower dose of the therapeutic agent. And that's why for gentamicin, we typically only use 1 mg per kg with the frequency adjusted based on the patient's renal function. Synergy for gram-negative infections is of major value only when the bacterium is resistant to one or both drugs in the combination. So sometimes when you get some of these patients with multi-drug resistance, you might use an antibiotic that is intermediate with an antibiotic that the bacteria is susceptible to try to have a synergistic effect. So you'll also see this with some patients who have maybe carbapenemase producing bacteria and it's resistant to everything, so you continue to use a carbapenem and you might boost it with an aminoglycoside at a low dose. So that's something that you'll see as well. But synergy between other drug combinations other than beta-lactam antibiotics and aminoglycoside combinations is really less predictable and has unclear clinical significance. So really the beta-lactam aminoglycoside combinations are the ones that we use the most and that we know are the most effective. So here's a listing of the bactericidal versus bacteriostatic antibiotics. So we look at the penicillins, cephalosporins, monobactams, which is aztreonam, carbapenems, vanco, dapto, fluoroquinolones, metronidazole, and nitrofurantoin all exhibit bactericidal activity. Those antibiotics that are bacteriostatic include tetracyclines, sulfonamides, trimethoprim, macrolides, clindamycin, and linezolid. Whether an antibiotic is bactericidal versus bacteriostatic can also depend on the drug concentration and the bacteria being targeted. So you definitely have to look at the guidelines, you definitely have to look at the minimum inhibitory concentrations for your specific bugs that you're treating, and look and see what actual serum concentrations are achieved with the different antibiotics that you use. Because you know what might be bactericidal for one infection with one bacteria might be bacteriostatic for another antibiotic with another bug combination. Erythromycin, azithromycin, and clarithromycin, those are all macrolides, have shown bactericidal activity against strep pyogenes and strep pneumoniae. And linezolid appears to be bactericidal against strep. So here are just some really good examples of when you can switch from being bacteriostatic to bactericidal. So in the previous slide we talked about bactericidal versus bacteriostatic antimicrobial activity. There are some clinical scenarios where bactericidal action is necessary. So it's necessary to kill off the bacteria and not just suppress their growth. Some of these patients may not be able to mount a very good immune system response, which is typical of how bacteria are cleared when there's just a bacteriostatic antibiotic being used. You're knocking down the level enough such that the immune system can just take care of things. But clinical scenarios where bactericidal action is necessary include endocarditis, meningitis, osteomyelitis, and neutropenia. Bactericidal activity, though, can be harmful. So many bacteria produce a substance called endotoxin, and it's actually endotoxins when a patient is septic that can cause that rapid drop in blood pressure that you see with a severe sepsis syndrome or septic shock. But it can be necessary in order to eradicate the infection. Another instance where endotoxin surge can be harmful is in infants who have meningitis with gram-negative pathogens. This endotoxin surge can cause elevated intracerebral pressure and fluid changes that can be harmful. There's also strep pneumoniae meningitis. So you have production of increased cell wall fragments and intracellular pneumolysin, which increase the white blood cell response and prostaglandin release. And that can also cause cerebral edema and a very high mortality rate. Bacteriostatic drugs are beneficial in slow-growing bacteria that are not affected by bactericidal beta-lactams. And so, when you're really talking about slow growers or you're talking about getting your immune system to work, those types of infections, it's less critical that the antibiotic exhibit bactericidal activity. So what are some of the pharmacodynamic determinants of antimicrobial efficacy? If we look and see, so what makes an antibiotic successful? And how do we adjust dosing or frequency in order to maximize the effects of the antibiotic? So when you increase or decrease a drug dose, that is going to primarily affect your Cmax, or your maximum concentration in the blood, versus MIC ratios, and your AUC versus MIC ratios. So your AUC is the overall exposure to the drug. Increase the dose, you increase the Cmax, or you increase the exposure to the medication. Decrease the dose, and you've decreased the Cmax, and you've decreased the overall AUC. Dosing intervals primarily affect the AUC versus MIC ratio and the time above the MIC. So if you decrease the dosing interval, you typically increase the AUC versus MIC. And the time above the MIC is increased as you decrease the dosing interval because you're giving the antibiotic more frequently. Infusion time primarily affects the time above the MIC. So that's for these for these time-dependent antibiotics such as beta-lactams. By giving them at a specific dose over a continuous or at least an extended infusion period of time, that actually really helps the bacteria or the antibiotic to work more efficiently. Some additional pharmacodynamic determinants of antimicrobial efficacy, you have to really appreciate which of your antibiotics are time-dependent killers versus concentration-dependent killers, because you're going to dose them different ways. So the time-dependent killers we talked about before, they lend themselves to extended infusion, to perhaps continuous infusions, whereas the concentration-dependent killers, you want to get a very large dose, a peak, and then you want to let it basically run to almost nil when it comes to serum concentrations, and then give another dose. So examples of time-dependent killers are beta-lactams, erythromycin, carbapenems, aztreonam, linezolid, clinda, vanco, azithromycin, tetracyclines, and tadizolid. The ones that are in blue, clindamycin, vancomycin, azithromycin, tetracyclines, and tadizolid, also exhibit AUC versus MIC dependent killing. Concentration-dependent killers include aminoglycosides. That's why once daily or extended interval aminoglycoside dosing is so efficacious. You get one large dose, and it's able to eradicate a lot of the bacteria. Fluoroquinolones are also concentration dependent. That's why it's important that you make sure that you're using the appropriate dose based on the indication and also based on the patient's renal function. Daptomycin, telithromycin, and telavancin, Vanco's more expensive cousin. What also helps with activity is where the antibiotic is distributed to. So does it stay in the blood system, or does it get separated into the fatty tissues? So for distribution, lipophilic ones will be more likely to penetrate tissues. That would be fluoroquinolones, macrolides, rifampin, and tetracyclines. Whereas more hydrophilic aminoglycosides, beta-lactams, and glycopeptides, which is vancomycin, tend to stay in the serum more. So when we're looking at treating an infection, we have a generalized approach. And this generalized approach, is very important that antibiotics get started as quickly as possible and that the empiric therapy be as close to what you need as possible. So we definitely have to utilize our antibiotic guidelines and all the different risk factors our patients have in order to determine the appropriate empiric therapy. So empiric therapy, you have a diagnosis or a general idea of where the infection is coming from. You typically give this therapy for 24 to 48 hours. After that time, you look at more targeted treatment. So you start to get culture results back, and you usually give this targeted treatment for about 24 to 48 hours. So you then de-escalate to your definitive treatment. So definitive treatment we usually define as, what are you going to be on throughout the rest of the course of your therapy. So we know that it needs to be narrow spectrum, and we know that it needs to be oral if possible. And so you use your guidelines to determine what would be the best treatment possible for those patients. So incorrect empiric therapy can greatly increase mortality. So they say that your mortality risk goes up by 30% for every hour you delay past 3 hours in getting antibiotics on board for septic patients. Not getting antibiotics on board is basically the same thing as getting inappropriate antibiotics on board. You're going to have longer length of stay, higher mortality, higher morbidity. Your patients just are not going to do well. What you have to consider with empiric therapy is where is the likely source of infection, because we know that there's a correlation between the type of pathogens you're looking for and where the source of infection is. What are the likely pathogens based on the site of the infection? What are the risk factors for multi-drug resistant pathogens? Where did your patient come from? Did they come from the nursing home? Have they had chemotherapy? Are they somebody who has been infected multiple times in the past with a multi-drug resistant pathogen? Are they colonized with a multi-drug resistant pathogen? Patient's prior infection history. That can also be predictive of future infections. What's the spectrum of coverage of the antibiotic that you're using? What formulation are you using? There's some formulations that are going to work well for some infections rather than others. One good way to think about that is IV versus oral vancomycin. IV vancomycin does not get pushed into the gastrointestinal tract. So to try to use IV vancomycin to treat C. diff infections would be completely fruitless. Whereas oral vancomycin does not achieve systemic concentrations, stays in the gut, and is ideal for C. diff infections, but cannot be used to treat cellulitis. What's the bioavailability of the product? How much does it move across the blood-brain barrier? So if you're treating meningitis, you want to get an antibiotic that's going to be able to penetrate the blood-brain barrier. Adherence. So what is going to cause a patient to be adherent to the therapy? So especially when we get down to definitive treatment, we're discharging them from the hospital, and we want them to go home on a couple of days of oral therapy. What is going to make sure that they take the rest of the doses as they're supposed to take them? And then cost. So what gets paid for, what doesn't get paid for, what can the patient afford, what's appropriate. Empiric therapy also has to take into account allergies or intolerances, and you really have to define whether these are real or not. There are some instances where really penicillins are the first line therapy. One of those is for endocarditis. So you really like to use nafcillin for those patients. But unfortunately, there's a lot of patients out there who report a penicillin allergy. So that might be a patient where we have to do some kind of penicillin desensitization protocol or do scratch testing to see if the penicillin adverse reaction is real, and be able to tease out adverse reactions like nausea, vomiting, diarrhea versus actual allergies. Organ function. We know a lot of our antibiotics have to be adjusted for renal or for liver function. Drug-drug interactions. A major drug-drug interaction between antibiotics and other agents is meropenem and valproic acid. So meropenem can cause valproic acid concentrations to drop significantly. And whether you're using valproic acid as a mood stabilizer or you're using it for seizures, your patient could relapse in both scenarios with greatly reduced levels. Patient-specific contraindications or precautions. There's some patients that for specific reasons cannot receive specific antibiotics. Concentration of the antimicrobial agent at the infection site. So does it actually penetrate the area that you want to treat? And then local resistance patterns. Um, Ingalls does have an antibiogram for its hospitalized patients, and we take a look at that to determine, okay, what antibiotics should we be avoiding and which ones should we be using based on our local resistance and sensitivity patterns. So we take a look at the different sterile sites of the body because they're obviously not supposed to have any bacteria present. So when you get a sample from one of these areas and it does have bacteria in it, you have to ask yourself, is this contamination or is this infection? So sterile sites in the body include the blood, the bone and bone marrow, cerebrospinal fluid, joint fluid, muscle, pericardial fluid, peritoneal fluid, pleural fluid, lymph nodes, and vitreous fluid. It also includes the brain, the heart, the liver, the pancreas, the spleen, ovaries, kidneys, and other internal organs. Obviously, dirty sites include the skin, the mouth. Another dirty site would be the gastrointestinal tract. So when you think about infection site, someone comes in and they think that they have a lung infection. So you look at pneumonia, community acquired. The most frequently identified pathogens are strep pneumo, Haemophilus influenzae, and Staph aureus. And there's also atypical agents, Mycoplasma pneumoniae, Chlamydia pneumoniae, and Legionella pneumophila. And then for TB, which TB is still pretty rare, but we do still see some cases around in Harvey, you would be looking for Mycobacterium tuberculosis. But basically, where you think the source of the infection is, those are the agents that you want to target, which is why when we look at pneumonia again, we want something that's got good gram-positive coverage, both gram-positive cocci and gram-positive rods, since Haemophilus influenzae is a rod, and good atypical coverage. So our first-line therapy on our pneumonia protocol currently is ceftriaxone, which covers strep pneumo and Staph aureus and Haemophilus well, and then we've got azithromycin, which covers the atypicals well. So when we're looking at sources of infection, a lot of times the infection is caused by displacement of normal flora or colonizers. So normal flora is just the bacteria that you normally have living on your body. There's a lot of really interesting studies that are going on right now that talk about the composition of your normal flora and how it potentially impacts different disease states that go on. They're really looking at people's biomes and trying to draw lines between chronic illness and restoration of a normal biome. Colonization, there's certain bacteria that can become colonized in different areas. The most frequent one that we think about in healthcare is MRSA in the nares. So that displacement, so say you have something that happens and it causes it to become displaced from your nose into your lungs, then that could cause a MRSA pneumonia. So what are the most frequent situations where the displacement of normal flora or colonizers that can cause infection? One of those is immunosuppression. So, patients who have their immune systems suppressed, whether they're getting chemotherapy or they're on some kind of immunologic for rheumatoid arthritis that causes immunosuppression, they're at higher risk for contracting different organisms. Broad-spectrum antibiotics can leave you at a higher risk for infection when they're used inappropriately because it knocks down your normal flora, and your normal flora is what typically fights off infections from actually happening. pH alterations. We talk about that with different sites within the body, that a change in pH can cause you to be at higher risk for cystitis, for urinary tract infections, for bacterial vaginosis. Breaks in the skin. So your skin is a major organ that is used to protect your body, and a break in that skin and movement of the normal flora internally past the epidermis can cause different types of infections. Perforation during surgery. So you nick the colon or you nick the bowel somewhere and you get spillage of bacteria and gastric contents into the peritoneal cavity, which is supposed to be clean. That can cause infection as well. And then indwelling devices. So this is a huge issue. So without having proper catheter care, both urinary catheter and then also intravenous catheters, so when we place PICCs or when patients have ports placed, these indwelling devices can serve as a place where bacteria can colonize, especially pathogens, and create a recurring place where they can seed either the bloodstream or they can seed the bladder or the urinary tract and cause infections. So some risk factors for resistant organisms include antimicrobial exposure, and we talked about that before. If you use antibiotics inappropriately, you knock down all your good bacteria, and then they're not there to fight off the bad bacteria. Your infection history, whether you're colonized with something, how often or what types of healthcare settings you've been exposed to, if you've had a prolonged hospitalization, if you have an invasive device, your different comorbidities, including diabetes and chronic kidney disease, and whether or not you're immunosuppressed. So when we talk about selection of appropriate antibiotic, we talk about antibiotics getting to a good concentration at the site of infection. So if you have somebody who's got pneumonia, you want to use an antibiotic that's got good lung tissue concentrations. Some of the ones that we see here that have very good penetration would be macrolides. A good example of that is azithromycin. Fluoroquinolones like Levaquin. But then we also see that there's some that don't have as good penetration. So aminoglycosides have poor penetration in critically ill patients. Colistin has variable penetration. We usually only use that if we've got, super multi-drug resistant stuff. And beta-lactams have variable penetration and may require more aggressive dosing or a longer infusion time, which is why you might see Zosyn 4.5 grams being used every 6 hours or maybe even every 4 hours for patients who are really acutely ill. But when you get up to doses that high, you start to worry about neurotoxicity and seizures. You also want to take a look at urine concentration. So if you're going to treat a UTI, you want to use an antibiotic that's going to get high concentrations in the urine. So those that achieve high concentrations include the beta-lactams, include the quinolones, nitrofurantoin, Bactrim. But antibiotics that achieve low concentrations in the urine, it's just really not a good idea to use them. So tigecycline, doxycycline, and moxifloxacin do not achieve good urinary concentrations. Moxifloxacin is also a respiratory fluoroquinolone, which means it's got much better gram-positive coverage than gram-negative. And we know that most UTI pathogens are gram-negative, so we would definitely want to avoid moxifloxacin for a number of reasons. And then macrolides achieve low concentrations, but sometimes those concentrations are just high enough to help out. So here's an example of the Ingalls 2016 inpatient antibiogram. So we take a look, this is for gram-negatives. So we see a listing of all the different pathogens that have been isolated on the left-hand side, and then different antibiotics that we test for on the top. Please note that Levaquin is used as a surrogate marker for fluoroquinolones. So if you see Levaquin, then you can assume that ciprofloxacin has the same sensitivity. One of the things that we've identified in antimicrobial stewardship is that we have an issue with urinary isolates being sensitive enough to the fluoroquinolones. If we look at our E. coli or non-ESBL, and that's extended spectrum beta-lactamase, we'll talk about that probably in the second or third lecture, we have a sensitivity of only 70%, which means 30% of all of our isolates that we get are actually resistant to quinolones. So what happens if you start therapy with a quinolone and you're one of the 30% that's resistant? Well, you may develop a worse infection, you may become septic, you may go into renal failure. So it's something to really take seriously to get the antibiotics right the first time. When we look at all isolates of E. coli, including the ESBLs, we see that our sensitivity is only 65%. We look at another urinary pathogen, Proteus mirabilis, and only 55% are sensitive to quinolones. And then we look at Pseudomonas. So Pseudomonas, we actually use Cipro to test because Cipro is the better gram-negative covering antibiotic. But even for Pseudomonas, we've got 25% of our isolates that just are resistant to ciprofloxacin. So it's really not a good idea to use ciprofloxacin for empiric treatment of Pseudomonas. This is an example of our gram-positive part of the antibiogram. So we see our different isolates on the left, and we see the different antibiotics on the top. We see that vancomycin is still doing well here when we look at MRSA. There's 100% sensitivity, which is fantastic. They've seen a lot of what's known as MIC creep at other institutions, where the pathogens are getting more and more resistant to vancomycin. They start to see that creep. When you talk about outpatient MRSA infections, so say you get a skin and soft tissue infection, we see that Bactrim still has really good activity. Linezolid should have very good activity. Linezolid is definitely not a first-line agent. It is pretty good for MRSA pneumonia, although it is a bacteriostatic agent and not bactericidal. When we look at other pathogens, we can look at Enterococcus. And so when we look at Enterococcus faecalis, we see that it's 100% sensitive to ampicillin, only 50% sensitive to Levaquin, 100% sensitive to linezolid. Vanco is 100% and Tigesil is 100%. But we know that if we are going to treat it, the penicillins are the best. They have the narrowest spectrum, they're the least expensive, and they have 100% sensitivity. This is the ICU-only antibiogram, and if we take a look again, we see problems with the fluoroquinolones in treating the different pathogens. If we look at all of our E. coli isolates from the ICU, only 59% were sensitive to Levaquin. For Proteus, only 36%, and for Pseudomonas, for some reason we had a little bit of an uptick. I think it had to do with a different N. But for Pseudomonas, we see Aztreonam not doing very well, and we see Cipro not doing very well. So we really have to take that into account. So ask yourself, take a look at this, and ask yourself if you thought somebody had an infection with Pseudomonas, so say you thought they had a pseudomonal pneumonia, what would be your choice for empiric treatment? We also take a look at our ICU antibiogram for our gram-positive pathogens as well, and we see that again vancomycin is doing very well at 100% for MRSA. And we also see that Bactrim is doing very well as well. When we look at strep pneumo, we see that ceftriaxone is doing very well at 93%. Levaquin is still at 100%. And vancomycin is at 100%, although vancomycin is super duper overkill when it comes to strep pneumo. You definitely want to use your Rosefins or your Levaquins for your pneumonias. So we talk about inappropriate antibiotic therapy, and what does that even mean? And what causes that? So some of the causes of inappropriate empiric therapy that I've seen have been provider fears. They have a fear of error or missing something. So they use too many antibiotics, or they use antibiotics that are way too broad, that there's just very, very little likelihood that they're going to see the pathogen that they could possibly see. I used to work with a doctor who would literally start 5 different antibiotics on every patient who had sepsis. It's way too many. Not believing that the culture data that is available. If you get a good culture sample and it's negative, chances are the patient does not actually have an infection. Now there can always be sampling errors, and that's why a lot of times you'll do serial blood cultures, but typically after you've started antibiotics, that blood culture is going to be close to negative. I've also heard this one, which is my patient is really sick, so they should have more antibiotics. You can actually make your patient even sicker if you give them more antibiotics. We have had a couple different instances of C. diff outbreaks here, and we'd really like to keep that under control because C. diff can kill people. The patient improved while receiving antibiotics, so we should continue them. Sometimes patients just get better. They don't necessarily have an infection. All signs point to a lack of infection, but yet we continue to treat them with antibiotics. Incorrect identification of an infectious source. So we talked about how important it is to identify the source of the infection because different sites of infection have different likely pathogens. And so if you think somebody's got a pneumonia and you're treating for a lot of gram-positive stuff, but in fact they have an intra-abdominal infection, which is primarily gram-negative and anaerobic, well, you're probably going to wind up with someone with a worse infection. And then a positive culture with colonizing organisms and not an active infection. So you have to be able to tell, especially for those skin and soft tissue infections and for those urinary tract cultures, which ones are infections and which ones are actually colonized. And in the next lecture we'll go through some culture data and talk about that. Some really common colonization situations include asymptomatic bacteriuria. which is you got bacteria in your urine, but you have absolutely no symptoms of a UTI. These patients should not be treated at all with antibiotics unless they are pregnant. When patients are pregnant, they have a really high risk of these bugs ascending the ureterogenital tract and causing an infection in the developing fetus. Foley catheter colonization, boy oh boy, those things get very colonized. They create something called a biofilm, which is almost like a little microcosm where the bacteria have created this ideal environment for them to grow. They're not infected, they just like to hang out there. Tracheostomy colonization and chronic respiratory failure. So you have chronic vent patients, and they just get chronically colonized with different bacteria. Chronic wounds and decubitize. So you've got somebody who's got just chronic wounds, typically on their legs. They tend to become colonized, and that's why it's important to be able to interpret a wound culture appropriately. Lower extremity stasis ulcers. And then chronic bronchitis. You'll see this with a lot of COPDers. They tend to become colonized and not actually infected. So what are the types of antibiotic misuse that we like to fight the most? One of them is treatment without clear evidence of an infection, treatment of a positive culture without evidence of infection, and not de-escalating. So not switching to a more narrow spectrum, not reevaluating, and we see a lot of times where either physicians or our ID physicians are not de-escalating until the point of discharge. Patients are typically taking oral or doing better midway into their stay and can typically be de-escalated. When we talked about empiric therapy, we talked about empiric therapy for 24 to 48 hours, then tapering down therapy for 24 to 48 hours, and then definitive therapy from there on if therapy is still needed. So what's the pharmacist role in antimicrobial stewardship? So your job is to be an excellent antibiotic steward. Your job is to learn the spectrums of activity for the different antibiotics, be able to use the antibiotic guidelines in order to start empiric therapy that's appropriate, expedite first doses of antibiotics to make sure that antibiotics get on board as fast as possible. It's our job to make sure that this is right. We are the drug experts. And, while other issues can happen, there can be delays in nursing administering, we don't want pharmacy to be the rate limiting step. We need to be able to have intelligent conversations with providers about antibiotic use and de-escalation so that we can ensure that the appropriate antibiotics are being used at the appropriate time or that they're discontinued if it's not appropriate to use antibiotics. So how do we be an excellent steward? Ensure empiric antibiotic selection is correct. Evaluate cultures to identify colonization versus infection and asymptomatic bacteria that doesn't need to be treated, and recommend discontinuation of antibiotics. Follow our patients daily to determine if treatment is still needed and recommend discontinuation when appropriate. I've seen this happen time and time in my short time here where I've looked at patients' profiles and they are still on antibiotics that should have been discontinued or that are no longer needed. If treatment is still needed, can it be de-escalated to a more narrow spectrum antibiotic, or can it be changed to oral? Can patients be switched from IV to enteral, and they need to be switched as soon as they meet criteria? Our new criteria now is 24 hours. So if they are meeting all the different criteria to be switched from IV to enteral, you need to do it as soon as possible. And then recommend narrow spectrum antibiotics when able. We also have to ensure antibiotics arrive at bedside in a timely manner and know the resistance patterns at Ingalls, so be able to speak intelligently about why we're choosing certain antibiotics rather than others. If you don't know how to evaluate a patient, if you don't know about a specific patient scenario, if you're confused, if the guidelines are confusing you, seek assistance from the clinical specialists, especially Navenka, or you can come to me anytime and I'm happy to go through cases with you. Alright, so this is the end of part 1. Hopefully it wasn't too painful, and we'll be moving on to part 2 coming out very soon.